Welcome to Hello everyone, and welcome to another PVACCS ICU mini-series webinars. And today we will be talking or diving deep into acid-base interpretation. Before we go into today's structure of tonight, I'd just like to begin by acknowledging the traditional custodians of the land on which we gather today and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islanders peoples here today. Rachel, could you just go on to the next slide, please? Thank you. So in terms of tonight's event and structure, it will be around about 60 minutes. We're going to be covering acid-base physiology, a bit of the cause of metabolic and respiratory acidosis, and going through some case studies. At the end, we'll have some time for some questions for about 10 to 15 minutes. And as normal or usual with us, feel free to send through questions during the event via Slido. And I think on the next page, we have the QRS code and the link there for you guys to put your questions through. All right, now I'd like to pass on to Matt, who will introduce our sponsors for tonight and our first speaker thereafter. Thank you, Matt.
Hi again, everyone. Good to see you back. Obviously, these events require sponsors in order to happen, and we're really appreciative tonight to have Dr. on call once again, represented by Amanda, and Ambos represented by Kim, supporting us. We really appreciate all your contributions in making these things possible. So I guess I'll just give you guys the opportunity to say hello.
Hi, my name's Amanda. I'm from Dr. On Call. I'm the Candidate Acquisition Manager. Thank you very much for giving us the opportunity to sponsor your organisation, and we're happy to be involved in your training tonight. I just want to give you a little bit of a rundown on Dr. On Call. We're a locum agency for doctors PGY2 and above. We have placements throughout Australia in private and public hospitals. So anybody that's interested in doing any locum work at all, there should be a QR code on your screen there for Dr. On Call. If you want to scan that, pop your details in, and then I'll be able to get in touch and have a bit more of a chat to you about it. But there's lots of different opportunities out there, and we fit in with each individual doctor to work on what they want to do. So plenty of opportunities. If you're interested at all or want any more information, just scan that QR code and get in touch, and I could give you a call.
Beautiful. So I hope everyone goes ahead and scans that barcode. I'll give you a moment to do that, and then I guess we'll just continue on. All right, next slide. Thank you.
I'm not sure. Sorry, Kim from Ambos here. Hi, guys. Is it possible to quickly share my screen? Because I have a QR code for everyone here as well and a few slides.
Just give me 1 minute. There we
go. Awesome. Thank you so much. Hope this works now. Okay, just a very few slides. First of all, hi, everyone. Thanks so much for having us tonight. My name is Kim. I'm one of the partnership managers for Ambos here in Australia. I studied medicine in Germany and worked for 2 years, did trauma and orthopedic surgery before I joined the Ambos team over here. Many of you will know what Ambos is. Ambos is a massive library combined with a question bank that also has an analysis section to track your study progress. Everything in our platform is properly referenced, and we have a very extensive review process in place to make sure that everything you look at is always correct and up to date. I personally used Ambos pretty much every day on the wards as well, even throughout my residency years, especially using our mobile apps, and would quickly like to share a few things of why Ambos definitely can support you, even if you are already in your clinical years, and especially also if you are a junior doctor on the wards. Just to give you guys one example, for example, during my first night shift, I got a call. As I said, I was working as a trauma reg, but we also had a department for OBGYN in the hospital, and they would deliver babies at night sometimes. And during my first night shift, we got a code and were ordered down into the delivery room because the neonate had an arrest. And within those few seconds that I had in the elevator, I pretty much got my Ambos app out and just looked at the most important things to remember, because this was definitely out of my scope in this moment. And I was really happy to have Ambos in my pockets to look up these things. And especially when it comes to being a junior doctor on the ward, we also have a new clinician mode, and there are a few more features in Ambos now that are supposed to help you as a junior doctor. A few things to mention is acute management checklist, red flags, but also things like drug dosages. And we also have a brand new catalog style drug database embedded in the platform now, so that you can pretty much have everything in one app that you need. As you can see here, there are drug dosages included. So whenever there's a medication stated, you can hover over them and you'll see the drug dosages. And you can also type in medications and you get this drug database that gives you all the important interactions and indications to look out for example. So really, really handy. Try it out, type in any medication and go through it. And we also have a free trial for everyone that is here tonight. If you scan the QR code, you can get a 14-day free access code. You're not entering a subscription. It's really just to try out the platform. And there's also a prize raffle where you can win one of 2 6-month plus codes. So I hope you guys enjoy this and have a look at the platform. And again, thanks so much for having us tonight, and have a good session.
You're very welcome. Thanks for being with us tonight. Having thanked our sponsors, I think it's appropriate to thank our speaker tonight. So we've got John Lee here delivering our talk. He's an advanced trainee in ICU. He's actually the senior registrar currently at Monash Health with loads of experience, and I'm sure he'll be very interesting and helpful for us tonight. So when you're ready, take it away, John.
Thanks. I'll just try and share the screen. Is that popping up for everyone?
Yeah, perfect.
Yeah, good. So hi guys, my name is John. As I've introduced, I'm an ICU advanced trainee at Monash Health. Let's be talking about acid-based interpretation, but I'll try to make it as simple and easy to remember as possible, because if you really go into depth, you can really get lost in the amount of detail that you have to know. So I'll try and make it as simple as possible. I'll start off with the introduction to acid-based physiology today, as well as a simple step-by-step approach to blood gas interpretation, causes of metabolic and respiratory acidosis and alkalosis, and some examples. Starting off with the introduction, and as well, if you guys have any burning questions in the middle, just feel free to put it in the chat if there's anything urgent. Otherwise, there'll be a slide or I think we'll address some of the questions that are asked. So pH, as a lot of you guys might know, is a measure of acidity, and it's important to keep regulated to maintain cellular function. pH is derived from hydrogen ion concentration with using the following equation that people might have seen before. And it's very highly regulated between 7.35 and 7.45. And you'll find that 3545 is a very commonly repeated value in the blood gases. There are various ways that it's regulated in the body. So the first thing that happens is there's a lot of chemical buffering that happens using a lot of extra intracellular buffers that prevents large swings in H+ concentrations. And then you have the body's mechanism to try and eliminate some of those kind of acidic compounds, such as CO2 in the lungs and bicarbonate control in the kidneys. This is a very oversimplified snapshot just to kind of let us know in the back of our minds what might be happening, although it's not a completely accurate representation. So over here on the left is a response to acidosis. So obviously you've got an addition of a acidic compound, which is either secreted in the kidneys or converted to carbonic acid to be excreted as CO2 in the lungs, or it's neutralized by the bicarbonate, which there's an ongoing infinite loop of bicarbonate in the kidney and the blood. And as I said before, there are some other buffers that exist intracellularly and extracellularly that help to mitigate some of the changes in acid concentration. And then the opposite happens here, where you can get elevated CO2 to try and counteract the removal or the alkalosis that happens from the removal of acid, as well as the generation of acid by secreting bicarbonate. I will go into a little bit more detail in the later slides, but this is a kind of overall snapshot of what is happening so that we get a bit of a feel. Now, everyone has a bit of a different step-by-step approach. There's obviously things that work for everyone, and this happened to work for me. You guys can tailor it however you guys find it helpful. But this is how I go about it, and it's just very simple and straightforward. Now, the first step I always use is to look at CO2. So I look at it and I say, is it high, is it low? If it's high, it's an acid. If it's low, it's less acid. So there's either respiratory acidosis or respiratory alkalosis. Same thing for bicarb. If the bicarb's low, treated as a base. So if it's high, it's basic, so it's alkalotic. And if the bicarb is low, then you've got metabolic acidosis. So now you have either isolated respiratory problem or isolated metabolic problem, or they concurrent. So you know that there are two processes or one process going on. And then what I do is look at pH. So when I look at pH, then I say, okay, look, are things compensating or is it the same? But I'll go into a little bit more detail in the later slides. And then if and only if you have metabolic acidosis, do you then look at the anion gap. And we'll talk a little bit more about what anion gap means and what we're looking for. And then the last step, which is not as important because there are lots of other measures of oxygen status other than the blood gas. And a lot of the time you're getting a venous blood gas, which is totally useless at looking at oxygen status anyway. But that's just an additional step I've added in case you want to practice trying to look at oxygen status in a blood gas. So I've tried to go through and kind of tried to explain a little bit more about each of those steps. So CO2 and bicarbonate, as you guys might know, is very closely interlinked in this equilibrium equation. This first part of the equation is driven by carbonic anhydrase, which is present in the lungs, in the kidneys, and in the red cells, a lot of places. CO2 is defined as a sort of volatile acid. So it's the only volatile acid in the body, meaning that it's one of those acids you can blow off or you can remove from the circulation from the lung. All other acids are considered non-volatile acids, but it's kind of academic, kind of knowing about those differences. CO2 problems will arise when you have an excess of ventilation or not enough ventilation. So that's when usually CO2 problems occur. And bicarbonate is primarily handled by the kidneys, and you'll see problems with that when you have a gain or a loss of bicarb or a gain or a loss of acid, depending on what disease process you're talking about. So normal, it usually means that the primary process or whatever is going on underneath has been compensated by a secondary process. So either you have a metabolic acidosis and you've compensated very well with your lungs to cause a kind of secondary respiratory alkalosis. And if you're compensated, the pH will be normal. Or if you have nothing going on, the pH might be normal as well. But if there is a primary disorder, you'll see that the pH has changed in the direction that you would expect there to be changed. So if there's a metabolic acidosis, you'd have a bicarb that's low, but you'd also have a pH that's low. And if the pH is low and you compare it up with a certain disease process, then you have your diagnosis. And anything else that's concurrent, like a respiratory alkalosis, will just be secondary. Now, as I said before, only if you have a metabolic acidosis do you look at anion gap. If you don't have metabolic acidosis, you can just skip this part. But if you do, it'll help us figure out what's going on and what's causing the metabolic acidosis. So the anion gap is, as you see in this diagram, it's the difference between the measured cations, which, there are a few other measured cations in the body, but the concentrations of these are usually largely negligible compared to the sodium concentration. So usually we only look at sodium, and the gap between that and the measured anions. So here is the bicarbonate and chloride, which are the main two anions in our body. And so this anion gap, or the difference between the cations and anions, can tell us a little bit more information. This gap is usually around 12 or below. If you add on potassium as a cation, then you'll have a greater anion gap that you'll consider normal, but normal is usually around 12 or below. Now, as you can see in this diagram as well, if you have an increase in anion gap, let's say the chloride goes down, or let's say the bicarbonate goes down, then this anion gap, or these arrows, will get larger, which also means that the unmeasured anions are going to get bigger, or vice versa. The unmeasured anions might have increased in your body, and hence the other anions reduce in size to maintain electron neutrality, which is the whole point of the anion. So that the plus and the minus is all even out. Now, an increase in anion gap, so unmeasured anions tend to be these. So lactate, ketones, salicylate, metabolic byproducts of toxic alcohol, or retained acids from renal failure. So really, if you have a elevated anion gap and you're wondering what is causing these unmeasured anions to be elevated, then you have to just look out of these. I mean, obviously there's other causes as well, but I'll go into the details of what other causes there are. But this is kind of the bare basics. And then just briefly about oxygenation, so that you at least know what to look for, so that you're not lost when you're looking at a blood gas next time. The best measure, as I said, there are lots of other measures of oxygen status rather than looking at blood gas. The best measure is actually clinical and bedside. So if the patient is GCS 15, they're perfectly perfused, they have no cyanosis, they're 100% room air, it doesn't really matter what the gas says. I mean, the gas can tell you that there are some maybe underlying V2 abnormalities, but really what's important is the patient in front of us. And also remember that a venous blood gas does not tell you anything about oxygen status. It's the arterial blood gas that's important. So make sure, if you really, really want to know what the oxygen status is like in the blood, then take an arterial blood gas. But a lot of the time, that's not really practical. Now, there are some measures of oxygenation that can be determined on the blood gas, but as you see on the last sentence, I don't usually look at any other measures other than the PF ratio, because they're a bit harder to calculate, or they're more unreliable. So PF ratio is just a very gross estimate as to how bad the hypoxia is. So really, it's a ratio between what the underlying arterial oxygen is and how much oxygen you're giving them. So if you're on, say, 100% FiO2, which is 100% oxygen concentration, and your PaO2 is only 70, it means even though you're requiring a lot of oxygen, your oxygen is pretty mediocre. So you should be a lot higher. So we say in a normal person, PaO2 should be 5 times the FiO2 that's being administered to the patient. So if you have a 21% oxygen saturation being delivered, 21% oxygen being delivered, which is room air, then a normal person's PaO2 would be 105. Or if you're delivering, say, 100% FiO2, maybe around 400 to 500. So that's a rough estimate. But there are other cutoffs that tell us the severity of respiratory failure. But as I said, this is a very gross figure. It just tells you a rough estimate how bad the lungs are at the moment. But there's no kind of detail about what it means, or what's the underlying pathology. It doesn't really tell you that. But at least you have an idea of, you can say they're hypoxic, their oxygenation is bad because of this reason. Okay. Now I'll quickly go through the different metabolic and respiratory acidosis and alkalosis. I'll try and make it fast because it's a long list of causes that I just have to go through. So metabolic acidosis usually results from an excess acid load. You're giving too much acid, or you're losing too much bicarb. Now, as I said, the causes of high and get metabolic acidosis are usually kind of set. There's only, the most common ones tend to happen quite often, more often than not. Now, cat mud piles is the long version that includes almost all of the detailed causes. But I found that left total knee replacement, or LTKR, is a pretty easy way to remember a truncated version of that, or a very simplified version. Cat mud piles, you can see a very long list might be a bit hard to remember exactly what the L was or exactly what the T was. Toluene, how often do you see that in hospital, or cyanide? There's a lot of drugs there, or a lot of medications that you may not see, but it's worth knowing, or worth knowing that the mnemonic cat-mouth pals. If a consultant asks you, and you can try and figure out what each of the letters stand for, or you can say, look, I don't really care about toluene or paraldehyde. I just know that left total knee replacement are the most common causes, and almost more than 80-90% of the time it's going to be one of these. And as you can see, toxins, very broad. So there's obviously a lot of things under toxin, but that kind of covers yourself in terms of not missing possible differentials. Causes of non-anion gap metabolic acidosis is usually due to a decrease in bicarbonate or an excess in chloride. Now, remember how I showed you the little diagram of anion gap, and how on the side there was chloride and bicarb on the right side. Now, if you have excess chloride, you can imagine the anion gap, or the difference between the cations and anions, is going to decrease. So that's why an excess chloride can cause a normal anion gap metabolic acidosis. And CAGE is the mnemonic that is commonly used. So chloride excess, so a lot of normal saline and ED is going to cause that. Acetazolamide or addisons. GI causes is probably one of the most common causes of non-anion gap metabolic acidosis, as well as the less common ones like renal tubular acidosis and DKA recovery. I'll try and get through to the cases because they're a little bit more interesting. Now, metabolic alkalosis usually requires an initiating process to first tip them over into alkalosis, but you also need something to keep them in alkalosis. So, for example, alkali is the mnemonic used for alkalosis. And if you see here, if you say loss of fluids is a cause of metabolic alkalosis, then if you have ongoing loss of fluids from your body, then that's a maintenance factor. Because otherwise, if you just have an insult that tips you into alkalosis for a little while, and there's no other factors that promote the ongoing alkalosis, then your kidneys are just going to correct it. They're too good at what they do. And there are other kind of more rare causes of alkaline ingestion called alkalosis, which is not as common. Sodium bicarbonate administration also not as common to cause significant alkalosis or ongoing alkalosis. Probably diuretics, loss of fluids are the most common causes. And then, obviously the aldosterone excess, which is also not as common. As I said, volume depletion and diuretic use are usually the more common causes. Hypokalemia, just due to the fact that you have hypokalemia and the interaction it has with the HK-ATPase kind of transporter, can cause ongoing alkalosis as well. Respiratory acidosis is the more commonly seen metabolic derangement on a blood gas. Usually results from hypoventilation, but it's not the only cause. If you think about it, respiratory acidosis is a low pH from a high CO2. That's what respiratory acidosis is. And that can be because we're not clearing enough CO2, but it can also be that you're just making too much CO2, or someone's giving you CO2 for some bizarre reason. I will go through some of those causes. Now, this is the normal, valves that you use, and there are other diseases that uses these same kind of mnemonics as well. But I've kind of come up with it just to make it easier for us to kind of remember what can go wrong. So airway obstruction. Now that's sort of to do with hypoventilation. So you're not able to move air in between your lungs and the outside world. Excess chest wall restrictions or neuromuscular disorders, lung chest wall defects like burns and restriction of the lung, they can all cause reduced ventilation. Intake. So this is where you're introducing CO2, such as you're rebreathing, or you've got excess CO2 in inspired gas, like if you're in a coal mine or if you're somewhere that there's just excess CO2 that's not being cleared and you're just breathing in a lot of CO2. As well as, this is a very common thing that happens. If you have a cholecystectomy or an appendectomy, you insufflate CO2 so that you can improve your surgical field or surgical field of view. And that can cause increased intake of CO2 and kind of elevate levels in your blood. And then you have overproduction. So you have malignant hypothermia, sepsis, diatoxicosis, convulsions, they all stimulate increased metabolic activity. So they can cause increased CO2. And then you have the underventilation, which is pretty self-explanatory. Respiratory alkalosis, really, there can only be one cause. There can only be hyperventilation. Hyperventilation is the one and only cause of respiratory alkalosis. What's important is why is it happening? So CHAMPS is a mnemonic that can be used to talk about reasons, but you know, a lot of these you can kind of figure out without having a mnemonic there. So if you're in pain, you're anxious, you're stressed, you're hypoxic, or you have other conditions that cause you to become hypoxic, they're all reasons for you to breathe significantly. So is sepsis. Now, salicylates is a very interesting thing. Now, if you remember, salicylates was also present in the, let me just try and go back if I can show you. Salicylates was also present here under high anion get metabolic acidosis. So this is very interesting. And it's only one that's commonly seen in patients that cause both the metabolic acidosis and a respiratory alkalosis because of the hyperventilation that's associated with salicylate poisoning. So those are the main causes, and hope kind of that's somewhat sunk into people's heads. There's a lot of things that I've mentioned, but let's just try and apply it, and it may hopefully make more sense. Now, case one. There's a 45-year-old male who has a history of obesity, OSA on home CPAP, and they're referred to ICU from the anesthetic recovery bay. They're immediately post-laparoscopic cholecystectomy, which is slightly difficult given the body habits, and it went on for longer than the anesthetist expected. They extubated as per standard post-anesthetic recovery orders, and the patient has been noted to become persistently drowsy, they have shallow breathing, and they're becoming progressively more unresponsive. And the anesthetist, being good anesthetist, has taken a blood gas and has placed the patient on a non-rebreather mask because they're a bit worried. And then they read you the results. And this is the blood gas you see. Now, I'll just stop for a little bit, a few seconds, so that everyone can take in the values. Have a think about it themselves in their head, what might be going on. But I'll make it easy for you guys, and I won't, single anyone out and just go through it after a few seconds. Okay. So pretty straightforward, but I'll have the blood gas noted on the next section as well, so we can go through it together. Okay. Now, let's take my approach. Now, as I said, everyone has a different approach. Everyone has their own way that works for them. Let's go through, what I do. So step one, you look at the CO2. Okay, the CO2 is 63, and the normal is 35 to 45. So this is elevated. So we know there is a respiratory acidosis without even looking at the pH. We know there is a respiratory acidosis. Okay. And that's there, 63.2. Step two, you look at the bicarb. Now, bicarb down there at 30 or 29.8. And bicarb ranges will differ depending on what blood gas you're looking at. Sometimes people will say 26 and above, 28 and above. Really doesn't matter. If you have a significant alkalosis, acidosis, you'll know about it. So here we have a mild elevation of bicarb, and this is a mild metabolic alkalosis. Okay. And then you look at the pH. So the pH is borderline low. So 7.35 is the lower limit, and here it's 7.295. So we know that there is an acidosis, the primary acidosis, and the pH is low. So now pairing these two together, you know that this patient has a respiratory acidosis with probably partial compensation by a concurrent metabolic alkalosis. Now, what I haven't covered in today's talk is assessing degree of compensation, because I wanted to keep it as simple as possible so that you guys took everything, as much things as possible home, so that you apply it in real everyday practice. Because if you're thinking about, what should the CO2 be, what should the bicarb be, it can get a little bit more confusing. So try this method and then read up on degree of compensation, and then you can try and add a few things one at a time. So here, roughly speaking, we know if they have a CO2 of 63, maybe their pH should be a little bit lower, but their bicarb is a little bit elevated, so there may be a partial compensation going on. Now, step 4, if you guys might not remember, is anion gap. There's no metabolic acidosis, so you skip that part. Step 5 is you look at oxygenation. So as I said, there are lots of other values on this gas that can tell you what oxygenation problems are going on, but we know we want to look at PF ratio. So the P is here, 57.7. And then the F is up there, it's 75%. So this patient is getting 75% of oxygen, and their PO2 is 57. Now, a PF ratio of 77, which is what it comes out to be, is extremely low. Okay, so as I said, a normal person on 75% will be 5 times that, would be around, I don't know, about 375. But even then, PF ratio less than 300 itself is mild respiratory failure or mild hypoxia. And here it's less than 100, which is the most severe category. So this is severe hypoxia. So now we have 2 things going on. So we have type 2 respiratory failure, where you have a respiratory acidosis as well as an underlying hypoxic respiratory failure, likely from hypoventilation post-extubation. And that's probably because he's a little bit sedated after his operation, and he was just at high risk of doing that. You know, with a history of obesity, OSA on CPAP, he just had all the right ingredients for him to slowly and gradually obstruct his airway. Patient's hypoxia is also severe despite attempts at oxygenation with supplemental oxygen. So you have them on 75% non-rebreather, and they're still saturated, or they still have a PO2 of 57. So whatever you're doing is not working. So as the ICU you rush to tell the anesthetist, oh, this patient is really unwell. They need to be better ventilated. You try to go down and tell them, and they're already not there. They're already reintubated, and they're already on their way to ICU while you were busy interpreting the blood count. So another patient saved, but I guess, you know, you kind of rocked up to the party a bit slow, but that's, you know, you win some, you lose. So that's the first case. Now, the second case is a little bit more interesting. Now, the first case we just talked about is pretty stock standard. You'll see that very, very often. If you ever come to ICU or you ever go to theater as an anesthetic person, you'll see it very often. This one, you won't see as much, but we'll talk about it. So an 80-year-old male found at home, unresponsive, and as per typical ED patient style, they have no collateral history, and they're also intubated on scene, so they can't talk to you, and they were transferred to ED. This is kind of patient you might just get, an undifferentiated ED patient that's very unwell. Now, interestingly enough, there were intraoral and laryngeal ulcerations that were noted when the tube went in, with chemical bottles at the scene. So things are getting a little bit more interesting. His blood pressure is currently supported on noradrenaline. Now that could mean anything, but it's probably a measure of the fact that this patient's a little bit unwell. His initial investigations reveal a mild AKI, a benign ECG, and a normal CT brain. So now you're scratching your head. Why has this patient become unresponsive at home? And why were they intubated? And why are they still unresponsive? So then you realize that a blood gas has been sent there, very appropriately so. And the patient's referred to the ICU for admission, even though we have no idea what's going on. Okay, that's fine. We'll work through it all together. Now, this is the blood gas that we see. And I'll give you guys a little bit more time to look at it because there's a few abnormalities. Okay. I'll keep the blood gas where it is on the left side of the screen so that we can kind of see it as we're talking. I'll try and go through everything. I know in an ideal world, I would ask everyone, you know, what's going on and get a lot of feedback, but there's a lot of us here, so I'll try and go through what we think might be going on. So number one step, look at CO2. Treat it as an acid. The CO2 is 43, so it's normal. It's in the normal range. So this person has nothing wrong with their respiratory system, or so it seems. Look at bicarb. Now, I don't know if you've seen the bicarb yet, but the bicarb is the number above the highlighted square right now. It's 8. Now normal is 22 to 28, so 8 is pretty low. 8 is pretty low, and the base excess, which is actually a better marker of metabolic problems, the base excess is minus 23, and normal base excess is about minus 2 to plus 2. So minus 23 is very, very, very low. So something is very, very wrong here. And not only do you see that from the bicarbonate base excess, but you also see it from the pH. Now, you don't commonly see people with a pH of 6.9 who are still alive and talking to you, which supports our theory that this person is unresponsive and is intubated at the moment. So it's kind of in keeping with how unwell this person is. It's profoundly low. 6.8 and below is usually not compatible with life. And 6.9, so it's very commonly seen people who have arrested and who have had no circulation to their extremities. But we see it in this patient, so we have to try and figure out what's going on. There is a primary metabolic acidosis because there's nothing really wrong with the CO2. Now, if we were to have to talk about compensation, we would know that the CO2 should be much, much, much lower than what they have there, because this person should be breathing up a lot to try and make their CO2 very low, to try and compensate for a pH of 6.9. But we have intubated this patient, and so we have complete control over their ventilation. So they have no say in how hard they have to breathe to try and blow off the CO2. So it looks normal, but actually it's probably a coexisting respiratory acidosis because the patient just does not have the ability to compensate with the respiratory system, if that makes sense. And then now we have a metabolic acidosis. Now we can use an anion gap rules. Okay, so anion gap is sodium minus chloride minus bicarb, and I've got the calculation there. It's 32, and as I said, normal is 12. And even if you said normal is 16 or less, it's still double 16, so it's still significantly high. So there is a high anion gap metabolic acidosis, and using our mnemonics from previously, we can look at left total knee replacement, which is lactate, toxin, ketones, and renal failure. Now, we don't know what this person's renal failure is on the gas, but we were told that this person has a mild AKI on the blood that returned. So it's probably not the cause of such a profound acidosis if there's only a mild AKI. So R is out of the picture. We can send off ketones for whatever it's worth. Let's say a normal. And then we'll look at lactate and toxins. Now, toxins we'll talk about a bit later. But let's say, has anyone noticed where the lactate of this patient is? You may have missed it because it's blank. Now, you don't usually see a blank lactate. There's maybe a line or some question marks if the analyzer's all gone wrong. But if you see here, there are 3 arrows next to the lactate. And in this analyzer, if you have 3 arrows next to the lactate, that's because the lactate is more than 30. Now, normal lactate is less than 2. So lactate of 30 is incredibly high. I've probably never seen a lactate of 30 or even something close to it, other than someone who had arrested or had remained, pulseless for several hours. Probably the only type of patient I've seen. Now you've looked at anion gap. Like last thing you can kind of cherry on top is oxygenation status. And here, the patient has a PF ratio based on the PO2 and FiO2 of 200. This is mild hypoxia. Maybe not even, nothing to write home about. But we know that the lung might not be the issue here. It's a conscious state. Okay. There's a little bit of thing. There's quite a few things to go through here. Let's just try and sum it up. So we've got a person who's got profound high anion gap metabolic acidosis, secondary to an ingestion of an unknown substance with subsequently reduced GCS. We have an undetectable lactate, which may be the only explanation, but given that this person actually ingested something must have caused the lactate. They wouldn't have drank liters and liters of lactate. So there must be something else going on. So let's look at toxins. Now, toxins are not very well looked at in the resuscitator process because we don't have many toxicology cases come through in other hospitals other than the Austin. So the Austin is the center of toxicology. I mean, there are obviously a lot of other EDs that see tox patients, but it's very unlikely you see very significant alcohol, very odd alcohol intoxications or toxic alcohols being ingested. So you're a smart ED resident and you want to order some tests. So This is just an extra, just a cherry on top of what we've learned so far. So let's say you order a serum osmolarity and that comes back at 362, and we don't have normal values here, but that's a little bit high. And the urea was 12. Okay, it's not too bad. Urea is usually less than 8, but okay, let's say a little bit high. And then you obtain a calculated osmolality. Now, you don't have to know the ins and outs of how someone came up with this, but essentially, this is how you calculate osmolality at the bedside. So it's 2 times sodium plus glucose and urea. And that comes to a calculated osmolality of 320-ish, which comes to osmolar gap. So the gap between what you've just calculated and what you've measured in the blood, the gap between that is 42.4, with the normal being less than 10. And osmolar gap is really good because it suggests that there's potentially a toxic alcohol in the system, or there are metabolites of a toxic alcohol in the system. So that kind of rings alarm bells, and that suggests that there's something else going on other than just a lactic acidosis. You rush to resus to tell your consultant, only to realize that the patient is already gone again, and they're in ICU, they're already on dialysis, and they're already getting a bicarbonate infusion. So even though you earned some points from the consultant, you can use it for another patient when they come to the. All right, so those are the 2 cases. Take-home messages. Step-by-step approach to gas interpretation allows you to process the information better, to simplify it in your head. Use mnemonics to start off, but I don't know if you also noticed, I tried to explain the underlying physiology. So what's happening? Am I adding bicarb, losing bicarb? What's happening? Trying to understand the physiology of why it occurs, you'll remember it better. But start off with mnemonics so that you get into the habit of interpreting them. Anion gap can help to distinguish causes of metabolic acidosis, but don't get fixed on a single cause. There may be multiple. And very vital to assess the patient clinically. But those gas are just numbers. If the patient is smiling on an iPad, absolutely symptom-free in front of you, that's probably a better sign than just not some numbers that are deranged. But obviously, numbers do concern us. And then practice. Pick up a gas whenever you get the chance. If you go to ICU or ED or MET calls, whenever you see a gas paper that's lying around, just pick up and read it and see if you can test yourself. And then look at the notes to see if you got it right. That's our presentation for today. I'll open it back up to the floor and for any questions that anyone has.
Thank you so much, John. That was incredibly helpful. I think we can all take away some tips on how to interpret blood gases. We'll get the Slido up and see what questions have come through. A few have come through.
I'm just going to share screen to show the Slido.
Thanks, Rachel. Alrighty, so I think the first question we have is, do you ever use SBE in helping you determine acidosis? I think that's PVACCS, mnemonic-wise.
Yeah, well, actually, I think SBE in this instance might be referring to standard PVACCS, which requires a little bit more calculation. But if it's not on the gas, practically, I'm not going out of my way to get a calculator to put in a few numbers. So if there's a PVACCS there that tells me -10, -20, +10, +20, that's all I'll use. But we do end up using PVACCS a lot more often than just bicarb. PVACCS is actually a lot more indicative of how bad an underlying metabolic acidosis is, if that answered their question. Any normal ranges for VBG? So VBG ranges can be quite unreliable. So I would probably, there are a few differences, like for example, PO2 is totally unreliable, so don't even look at it. I would reckon CO2 tends to be a little bit higher, bicarb tends to be a little bit higher, but kind of if you take into account laboratory inaccuracies and plus minuses, then if you use a very similar reference range, a lot of the time, if there's a significant derangement, you'll know about it. So, if the CO2 is 50 on a venous gas, you may not be as worried, but a lot of the time, if someone's really unwell, their CO2 will be 19 or their bicarb will be 10. So there will be no kind of ifs and buts usually, even with a venous gas, if that helps answer.
Next question, do you ever use strong iron difference instead of HCO3 bicarb when in differentiating metabolic alkalosis or acidosis?
This is a very somewhat controversial question. Now, strong iron difference is probably the outside of the scope of this talk, and it's probably a whole talk in itself. And for people who don't know what we're talking about here, strong iron difference is a whole new theory that someone called Stewart has come up with that essentially throws whatever idea we had about acid base out the door. So all this talk I'm giving about bicarb, acid going in and out, it's all useless. We have to learn this new theory, and everything we've learned so far is useless. But so strong iron difference and the Stewart theory is still it's a theoretical model, and it hasn't really kind of brought itself into the ICU scope of practice in terms of when we apply it to our everyday patients, other than for chloride problems. So if we know that a lot of patients have received a lot of sodium chloride in ED and the chloride is high and they're acidotic, then we have a very good explanation for why they are acidotic. But then again, we don't go into looking at what the strong iron difference is and making sure our strong iron differences are altered based on what we need. So I would say practically we don't use strong iron difference in ICU at the moment. Except for PaO2, can all of this be done using a VBG? Is PCO2 on a gas reliable? As I said before, very similar question to the reference range problem. So I would say realistically, in an everyday clinical scenario point of view, it probably is reliable to the point that you need it to be. But if I give you an example, we had a patient in ICU a few days ago who came in from the ward with a CO2 of 100 on their venous gas, and then we did the arterial gas, and the arterial gas was 75. And so there are instances where you may want to be sure if the patient looks extremely well, which this patient did. This patient was talking to you with a CO2 of 100. So there are instances, but everyday practice, venous gas probably does the trick. Would you mind explaining excess base or base excess again? Okay, so base excess is a very similar marker to, let's say, bicarbonate in terms of when we say we want to know about whether they're acidosis or alkalosis. So we know a low bicarb is acidosis and a high bicarb is alkalosis. But bicarb can change depending on what your CO2 levels are in your blood, just keeping it simple. So base excess means how much base do I have to add to get the blood back to normal pH? So let's say a base excess is -10. That means I have to add 10 worth of a base to bring it back up to normal pH. And that's why it's a bit more of an accurate measure of what the underlying metabolic arrangement is, or the severity of it, if that kind of makes sense. What's the significance of osmolar gap? So as I said in the previous slide, osmolar gap is used when you're looking for an unusual toxic alcohol as a cause of high anion acidosis. So that's really the one time you want to use it. When you look for all other causes of high anion metabolic acidosis and this person has consistently high anion that you cannot explain, then you do an osmolar gap, and that might tell you, okay, there might be some toxic alcohol that this person's ingested. And then how do we know whether to take arterial or venous blood gas? So very good question. If you're on the ward, you should probably take your venous gas for most of your problems. If there's say always say patient who's always hypoxic and you really want to know how hypoxic they are, then you might want to do an arterial blood gas in the respiratory ward just to get an idea. But really the only meaningful difference that the two have is the oxygen status. The other one, as I said, from an everyday practice point of view, the venous blood gas is a good substitute. And if you're in ICU, everyone's going to have arterial gases. No one's going to get venous gases because everyone has an arterial line. That kind of answers your question for you. So long story short, a lot of the time you're not going to be taking arterial gases from anyone. Okay.
All righty, I think that's our last question. I might just wait a few minutes to see if anyone else has
If
any
anything
other
pops up.
trickling questions last minute coming through. I'll just check the chat.
Oh, yeah, I see on the chat. I think there might have been one from a previous slide. So I'm not sure if, yeah, they're probably talking about the bicarb. So if the bicarb is 8, that would definitely be a metabolic acidosis. I don't know if I actually said metabolic alkalosis, but definitely a bicarb of 8 would be a metabolic acidosis. I'm sorry if I said metabolic alkalosis, I definitely meant metabolic acidosis. Yes, very true. So this case, they do have a higher lactic acid. And as I said, this may be the only factor for high anion gap metabolic acidosis. But then if you were to say, okay, then it's just the lactate, or let's say, okay, so this profound lactic acidosis, then it's just related to volume depletion or sepsis. I'm just going to give them fluid and forget about it. Then you might miss some other things. So because this person's taking a very unusual ingestion, you have a high clinical suspicion that there may be something else going on that may be the explanation of this profound acidosis and not just a lactate. And even though the lactate is very severe, you have to try and rule out everything else, unless you have very clear-cut, cardiogenic shock or septic shock. They have fevers of 42 and they're on a NORAD of 50. So, and their lactate is high. Okay, fine. Then we have no other, we might not go looking. But if you're not sure, it might be worth just probing a little bit. Yeah. That's about it from a question point of view. If anyone else has any questions.
Any last minute questions? Other than that, I think we're getting a lot of thank yous, John. You've done great. Fantastic.
Good. All right. Thanks everyone for coming.
All right. Yeah, I think we'll leave it there. I just want to thank everyone for coming along. I particularly want to thank John for giving up his time and volunteering his time to talk to us today. As usual, the talk will be is recorded and will be uploaded to our YouTube page. And keep out for our ongoing ICU mini series on respiratory failure, fluids and electrolytes, and intracranial hemorrhage. So keep an eye on our social media pages. So I'd like to thank everyone and enjoy the rest of your evening. See you guys.
All right. See you guys. Thank you.